Hi everyone, very important. We're doing the test for cerebellum today. That's the practical and the discussion. So these are the following features or signs which are characteristic of cerebellar dysfunction. In cerebellar dysfunction, patients normally experience hypotonia, which means that there will be diminished resistance to passive movements of joints. For example, if a doctor or an examiner is trying to cause any sort of passive movement at a joint. If, for example, they're trying to flex at the elbow joint, it will be easily done without any resistance. From the patient's side, there'll be no resistance at all. So because of that diminished resistance, it's basically hypotonia. The tone of the muscle has decreased. For now, let me just read the what do you call these? The titles, right? The bullet points, and then I'll go further in details. But I just cannot resist myself from explaining in detail right at first. Anyways, so hypotonia would be there in cerebellar dysfunction, change in posture and alteration of gait would be there, of course. There would be disturbance of the coordination of voluntary movement. That's referred to as ataxia. There would be pass pointing. For example, that's one of the tests. So when you ask the patient to touch the tip of the nose with index finger, so basically the finger goes beyond the nose, right? And so that's because of lack of coordination. There'll be nystagmus. Nystagmus are of two types, jerky and pendular. Pendular is basically just like this, right? And a jerky is like this. And then there's this gyrokinesia where the patient cannot perform rapid alternating movements. For example, you have to ask them to rapidly pronate and supinate the forearm, and the movement will be slow, jerky, and incomplete. Disturbance of reflexes, especially the deep reflexes, will be pendular due to hypotonia. Dysarthria, there'll be difficulty in speaking, and the speech will be slurred. Now let's discuss in detail. Cerebellar dysfunction. Cerebellar dysfunction, hypotonia. There'll be diminished resistance to passive movement of the joint that I've already explained. Shaking the limb produces excessive movement at the terminal joint because cerebellar influence on the simple stretch reflex has been lost. Other than that, posture would be changed as well because the shoulder on the side of the lesion will be lower than the normal side. And whenever the patient is standing, they will assume a very wide base. Their feet will be apart. So they'll assume a wide base in order to compensate for hypotonia, and their legs will be pretty stiff and wide base. Why? In order to compensate for the hypotonia, and especially when they're walking, so they'll be staggering towards the affected side. For example, if the lesion is on right side and right side shoulder is, it will be lower, and also they'll be staggering towards the affected side. So this is your alteration of gait. Let's just cover ataxia as well with that, and then I'll show you a video. So basically, voluntary movements, they can't be initiated or they cannot be coordinated. That's ataxia. So there'll be intention tremor, especially when a person is trying to perform fine movement skills, for example, buttoning the clothes, writing, or shaving. There'll be intention tremor because the muscle groups they fail to work harmoniously, and there's decomposition of movement. Pass pointing I've already explained to you. Other than pass pointing, there's one more thing. If you have to ask the patient to stand up, and this is basically performed on the lower limbs, and you have to ask them to place the heel of their, let's suppose, right foot on the shin of the left foot. So if they're able to do that and stand properly on leg foot on one leg, and they're able to maintain the balance, that means the cerebellum is all good and fine. If not, then obviously they'll have cerebellar dysfunction. Nystagmus is also there. Before that, let's just look at the gait. So I was trying to tell you about the gait. So here you can see
उधर जाइए.
that's the gait in cerebellar dysfunction. Other than that, let me see if there's another. Yeah. Here you can see how the shoulder on the right side is lower, and also the patient is basically staggering towards that side. So this is the gait. Then after that we have nystagmus. Nystagmus is basically ataxia of the ocular muscles, rhythmical oscillation of the eyeballs, and pendular nystagmus and jerky nystagmus. So the quick phase is going to be towards the side of lesion. What does this mean? For example, patient quick phase is towards the left. Quick phase on the left side of the lesion, probably. This is
I heard
pendular
about these products.
nystagmus.
People that talk about it like it's something personal,
This
like
is
they have kind of a relationship with it.
okay. That's a pendular nystagmus, and I've already showed you. I've already showed you the what do you call it? Jerky nystagmus. This gyrokinesia and ability to perform rapidly alternating movements. I've already told you.
Yeah, okay. And so now I want you to go
Just
as fast as you
let
can.
the patient understand what he has to do, right? So this is Dysautokinesia. Other than that, disturbance of reflexes, hypotonia, because of hypotonia, the deep reflexes will be pendular, dysarthria, ataxia of the muscles of the larynx, and articulation. Syllables are often separated when they pronounce. For example, tentative has three syllables, so they're going to say tentative. I don't know why this word it just came to my mind. So speech is slurred. So this is your cerebellar dysfunction sign. Hypotonia, posture, and there will be alteration of gait, right? That you can explain, and voluntary movements will be there will be lack of coordination, ataxia, and nystagmus would be their dysautokinesia, and disturbance of reflexes and dysarthria. You can also talk about fast pointing.